I'd like to thank the CSRS for inviting us to speak. These are our disclosures, none of which are relevant to this talk. So cervical spinal deformities represent a highly heterogeneous group of disorders. They're frequently part of a larger spinal malalignment, with co-occurrence of thoracolumbar malalignment being present in up to 2/3 of cases, depending on how this is defined. The typical profile of cervical deformity patients is different than our typical surgical patient, as they are more frail, comorbid, older, and have worse baseline disability, which translates into a higher prevalence of poor outcomes and a need for realignment. Causes of cervical deformities are multifactorial. Traditional causes such as inflammatory, arthritis are becoming less common due to pharmacotherapy. Dropped head syndrome is a rare cause, and advanced degenerative changes remain a common cause. But increasingly we're seeing iatrogenic, both post-cervical and post-thoracolumbar fusions being present in our practices as well as the literature. Cervical deformity post-thoracolumbar ASD correction is present in up to 63% of patients at 2 years post-operatively, 48% of which are new in onset, with risk factors being proximity to the cervical spine in terms of UIV, as well as the baseline cervical deformity that is present. We know that PJK increases the rate of cervical deformities even further, with adult spinal deformity patients adjusting for PJK with cervical malalignment onset, with increasing C2T3 angle and cervical lordosis. This is a patient of mine, a 61-year-old female with past medical history of rheumatoid arthritis and Parkinson's disease, who had an uneventful thoracolumbar scoliosis correction with a good initial outcome. However, by 2 years, she sustained a chin-on-chest deformity, requiring revision with a vertebral column resection, ultimately ending in a good result. This is a case example not performed by myself, who had a 4-level standalone ACDF procedure, and it's important to understand that these procedures, especially if not being very careful technically, can be kyphogenic. This patient did poor clinically. She had a postoperative MRI which delayed the revision, and by the time I saw her required an extensive reconstruction of the cervical spine. So one of the important questions we have to answer is, have we reached a consensus on treatment? And in summary, the answer to this is no. We don't have a clear understanding of relevant radiographic parameters specific to the cervical spine, and we don't have cervical deformity specific clinical parameters to go upon, and certainly while attempts have been made, there's no widely accepted classification scheme that we utilize. One of the early studies to highlight this disparity was by the ISSG, where a series of 18 adult cervical deformity cases were gathered and entered into clinical vignettes, including cervical and full spine imaging, and these were distributed to a panel of 14 deformity surgeons who performed at least 20 adult cervical deformity cases per year. Surgeons were asked to rate their osteotomies based on the following classification. This is a typical clinical vignette that was given to the surgeons. The surgeons were asked if they would perform an anterior procedure and exactly what they would do, as well as a posterior procedure as well and exactly what would be performed. Not surprisingly, a lack of uniformity in the surgical treatment was seen, with marked variation in treatment plans across all deformity types. Cases of cervical thoracic scoliosis had the least agreement, and there was a broad variation in the number of anterior levels, posterior levels recommended, as well as location of osteotomies. Variability persisted for mild and moderate deformity as well. Another important question for cervical deformities is, how do we adequately target and realign and reliably confirm our realignment? We know that this is a specific challenge in cervical deformities. Up to 1/3 of patients with asymptomatic states can have kyphotic cervical spines. One of the initial attempts to classify cervical deformities was by Ames et al. This included 5 descriptors as well as 5 modifiers, 4 of which were radiographic, 1 of which was clinical. This was performed via a modified Delphi approach, and as a result, this really correlated very poorly with postoperative realignment and outcomes. We attempted to modify these criteria by anchoring the patient's neurologic status and functional status by baseline MJOA scores, and this correlated a lot more strongly with postoperative realignment and clinical outcomes. And we also noted that cervical thoracic parameters such as the C2T3 angle and upper cervical angles such as C2 slope correlated more strongly. It's important to understand that many patients are unable to undergo major invasive corrective procedures due to their health state or their frailty state. As a result of this, we prioritize our parameters with the C2T3 angle showing the highest odds ratio of being correlated with postoperative MCID being reached. Even when we know the optimal realignment targets, there's challenges with surgical management, as up to 62% of patients remain malaligned. And this is where preoperative measurement and planning comes into play. The utility of proprietary software has been shown, as this can accurately assess preoperative measurements and allow surgeons to interact with their plan and the radiographs in order to establish alignment goals and thresholds for achieving clinical outcomes. One of the earliest cases where this was made evident to me was the following patient, a 63-year-old female patient, past medical history, osteoporosis and seizure disorder, who presented with severe cervical deformity and progressive neurologic dysfunction. She underwent an anterior-posterior reconstruction of her cervical spine and initially had an uneventful course. She was discharged on Forteo in a brace, and she was doing great at 3 months. However, by the time she reached her 7th month mark, after a minor fall, she sustained multiple injuries, both proximal and distal to her construct. And in assessing her deformity, we really realized that she essentially had malalignments in every region of her spine. The most notable was the lumbopelvic, as well as the upper thoracic. So given her frailty status, we decided to stage this and reassess our realignment goals. The first intervention was a lumbar PSO in order to achieve the most for our intervention. And this patient underwent this procedure with an L4 PSO that was uneventful. Following this, the patient did well, and we reassessed our goals, and her horizontal gaze was slightly undercorrected. Her thoracic spine was still hyperkyphotic, and she then underwent a vertebral column resection, ultimately achieved a good clinical outcome. So we have to choose the right procedure for the right patient. These are 3 cervical deformities that are occurring in 3 very different patients, with the not frail patient on the left having a 4-day uncomplicated hospital stay, and the severely frail patient on the right being discharged to inpatient rehabilitation after experiencing respiratory complications. And this led us to the development of a modified cervical deformity index, where the number of deficits were divided by the total deficits. And when looking at the invasive cutoffs with reaching MCID and no complications occurring, we saw that as frailty increased, there was less opportunity for increased invasiveness and good outcomes in avoiding revision surgery, as severely frail patients had an invasiveness cutoff of almost 20 points lower than that of frailty patients. We know that preventing junctional failure is particularly important in these surgeries, as the durability is affected by this. Rates reported up to 34% of distal junctional kyphosis have been seen in the literature. And while thresholds have been published, the clinical dimension of DJK has not been clearly understood. Some of the risk factors for this include preoperative cervical deformity degree, combined surgical approach, higher grade osteotomies, and the use of transitional rods. And our group attempted to look at symptomatic versus radiographic based on the occurrence of new onset neurologic symptoms. And what we found is half of symptomatic DJK cohort required a reoperation relative to the asymptomatic population, which very rarely required a reoperation. And this also translated into suboptimal clinical results, with symptomatic DJK patients having up to 4 times the odds of achieving poor clinical outcomes. We took this a step further with the development of a predictive model for DJK, combining clinical, radiographic, as well as surgical factors, which predicted the occurrence almost 90% of the time. And finally, I'm going to end with choosing end levels. With regards to this, the current surgical planning algorithms for cervical deformity correction do not specifically emphasize optimal fusion length and UIV level. When looking at the UIV, our group found that in severe deformities, if extending the construct to C2, this really had clinical as well as radiographic benefits with very little downside and almost no difference in range of motion. Certainly, this may be less relevant with the increasing usage of cervical pedicle screws. With regards to the LIV, we embarked upon 2 studies to address this. The first study looked at the LIV in relation to the degree of thoracic kyphosis, whether it was hypokyphotic or hyperkyphotic. And what we found was that patients who had a secondary thoracic kyphosis or hypokyphosis, and the construct was not extended beyond the apex of the thoracic kyphosis, this resulted in suboptimal clinical outcomes. Our last study looked at ratios of cervical to lumbopelvic parameters, and based on these ratios, at what point should the thoracic spine be included in the construct, and this showed to correlate very closely with distal junctional failure and reaching MCID. So in conclusion, there's a lot to learn despite us coming a long way. I'd like to thank you for your time.